care series on pediatric obesity. For our second session, looking beyond BMI, assessing pediatric health with the EOSS-P tool. My name is Denise Campbell-Scher. I'm the Associate Dean of the Office of Lifelong Learning and Physician Learning Program. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. Next slide, Natasha. Yeah, so I'd like to extend our land acknowledgement. The University of Alberta, its buildings, labs, research stations are primarily located on the territory of the Nihil, Niitsitapi, Métis, Stoney, Dene, Haudenosaunee, and Anishinaabe lands that are now known as part of Treaties 6, 7, and 8 in the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So just in terms of some logistics, I'd like to start with some housekeeping information for today's webinar. If you have any questions for the speakers, please use the Q&A feature of the webinar of Zoom on the bottom panel of your screen. Please review what's been asked and upvote questions you'd like to have answered. We can't guarantee that Stasia and Laurie will be able to respond to all of your questions. If you have questions more of a technical nature, please use the chat feature, which is on the bottom of the screen. A recording of the webinar and the Pearls document will be sent via email to all of those that registered for today's event. So participants can claim CME credits and complete a personal learning development activity using the My Lifelong Learning Plan tool. So for more information, please visit the QR code. Please also do not use AI note takers in today's session. Those have not been approved, and nor are they appropriate. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credit. And additionally, MainPro Plus participants may also earn additional certified credits by completing a linking learning exercise. So today we're very pleased to welcome back our colleagues, Dr. Stasia Hadjiyannakis and Dr. Laurie Clark, who will be presenting on looking beyond BMI, assessing pediatric health with the EOSS-P tool. Stasia, whom you met last week, is a pediatric endocrinologist and medical director of the CHEO Center for Healthy Active Living. She's an associate professor of pediatrics at the University of Ottawa and has been an active member of the Department of Pediatrics at CHEO and the Division of Endocrinology since 2002. Her clinical advocacy and research interests are in the area of pediatric obesity assessment and management, with a focus on the development and evaluation of clinical tools, such as the one we're going to hear about today, the EOSS staging system for pediatric and the 5 A's of pediatric obesity. Laurie Clark is a clinical psychologist and clinical investigator with the Center for Healthy Active Living at the CHEO as well, where she works with an interdisciplinary team to help children, youth, and their families achieve their best health. Her areas of clinical expertise include pediatric obesity, eating disorders, and body image difficulties. Laurie has contributed to the development of key clinical tools also, such as the 5 A's of pediatric weight management and the EOSS-P, and is actively involved in clinical research and program evaluation. So welcome back, folks. We're so excited that you're here, and I'm going to flip it over to you.
Thanks so much. It's great to be here again. Thanks for the invite. Thanks for coming back over your lunch hour as well. And so we're moving past the ask part of the 5 A's and into the second A, which is assessment, and hopefully provide you with some practical tools to use and frame your assessments for children living with obesity. We still do use anthropometric measures as a starting point. So BMI measurement and BMI curves, whether you're using the CDC growth curves in your EMR or your WHO growth curves in the EMR. And as we discussed last week, if you have historical data, if you've been following a young person for several years, it can be really helpful and meaningful data. So the anthropometric measures are a starting point. Your BMI is a starting point. It is a measure of body size. And again, we have a BMI classification system to identify severity based on BMI. So class 2 and class 3 obesity is defined as severe obesity based on BMI. And then again, you'll be able to have access to an expanded BMI curve, so you can more clearly see those different classifications. But as many of you in the audience recognize, BMI is a good measure of body size, but not necessarily a great measure of health risk. So we need to move beyond BMI and complete a fulsome assessment to really understand the health risk or the impact of having a higher body weight on the young person that we're seeing. And it can be very highly variable, and this is just an example of variability that you might see in your patient population. So here are two boys, Jeff and Aaron, both 12 years of age. Both have class 2 obesity based on BMI. So both have a BMI of 32, which is in the class 2 obesity category or severe obesity. But Jeff is doing very well. He's free of any metabolic health complications. He's free of any biomechanical health complications. He's got good health from an emotional and mental health perspective. He's well connected to activities that he enjoys. He's well supported at school and at home. So for Jeff, although he has class 2 obesity based on body mass index, for Jeff, I think our role is really to be there to support him, to ensure all of those wonderful things continue for him, to see him in follow-up, to continue to reassess his metabolic and biomechanical health at follow-up appointments, and to be there in case things change for him. And if any barriers come up for him. Aaron, on the other hand, also same age, same body mass index, but Aaron is struggling with some metabolic health complications of obesity, including type 2 diabetes. He has some ADHD and a nonverbal learning disability, which can complicate weight management for him. And his social supports are limited and stressful, including significant bullying at school, some difficulty attending school, and really a home environment that also that is not safe or supportive. So when you think about Aaron in terms of his health needs and think about prognosis for Aaron, we need to mobilize more resources to sort of support Aaron, and so his health risk is quite different than Jeff, and you wouldn't know that or recognize that by looking at body mass index alone. I know our adult colleagues recognized that early on and developed the Edmonton Obesity Staging System as a clinical staging system for obesity, which demonstrated really a more specific look at health risk beyond BMI. So when you look at BMI and survival curves, you see no real differentiation in survival, whether an individual has class 1, class 2, class 3 obesity based on BMI, but you do start to see differences in survival when you classify or use the Edmonton Obesity Staging System. So that really helps you differentiate or more specifically identify people who are at higher health risk or have higher health needs when it comes to obesity. And so when we saw that in the literature, we hope to try and adapt that tool for a pediatric population and worked across the country with pediatric obesity clinicians and researchers to try and develop a tool that we could apply it to our patient population. And our tool begins at stage 0 and ends at stage 3. And the 4 main areas of health that we assess are metabolic health, biomechanical health, mental health, and social health across each of those stages. And an individual has stage 0 obesity if they have absence of any concerns in any of those 4 M's. Stage 1 if they have subclinical concerns within any of the 4 M's. Stage 2 if they have clinically significant diagnoses, so a clinical diagnosis or clinically significant concern within any of the 4 M's. And stage 3 if they have both a diagnosis or clinical concern, but it's not well controlled or well managed, then it's stage 3. And we'll go through some examples of applying the EOSS-P. So the assessment, when you've gone through your ask, you have permission to talk about weight and assess for any weight-related health complications, you are going to then move on to complete this assessment. And a fulsome assessment is critical before you can give any meaningful advice. So really taking your time for the assessment. You can break the assessment up into multiple visits, and then only once you have gathered your data can we move on to advising around health risk and potential interventions. So you start with your anthropometric measures. You're going to do your height, your weight. You're going to calculate your body mass index. You're going to plot it on your growth curve and hopefully have historical data. And then you'll go on to assess your 4 M's to assess for and complete your clinical stage. When we think about the etiology of pediatric obesity, the majority of the patients that we see will have polygenic obesity. So that's an inherited vulnerability to developing obesity. There are certain intrauterine exposures that may increase our risk. Children with polygenic obesity have a normal growth velocity and are often tall in childhood. You do want to think of some of the more rare forms of obesity. So when to think about an endocrine cause, for example, a hormonal deficiency or hormonal excess that might be contributing to obesity, you would recognize that in a growing pediatric patient because they are not growing in height. So they're gaining weight, but not growing as you would expect in height. So if you have a young person with a low growth velocity in terms of height, and ongoing weight gain, then it is worthwhile completing an endocrine assessment. Some of the monogenic and syndromic forms of obesity are increasingly being recognized and important to diagnose because of multi-system issues that need surveillance and also therapeutic implications. Now, there are some unique therapies that are available to help manage some of the monogenic and syndromic forms of obesity. And you'll recognize those because kids with monogenic or syndromic obesity tend to present with severe obesity within the first 5 years of life, and often really within the first couple of years of life, especially with the monogenic forms of obesity. They often have coexisting hyperphagia, and that's a very strong drive for a strong hunger drive. So looking for food in between scheduled times, waking in the middle of the night to eat, perhaps foraging for food. The hyperphagia is significant, and the onset is early on. And in syndromic forms of obesity, you may also see some unique physical features, some neurodevelopmental delays that might lead you to suspect the possibility of a syndromic form of obesity. And then I refer to my metabolics or genetics colleagues to conduct the complete the genetic assessment and relevant blood work to identify whether these are present. And then finally, a small group or a group of kids that we see with significant obesity include those who have hypothalamic damage from a brain tumor, most typically a craniopharyngioma. These individuals, because the hypothalamus is damaged, will have difficulty regulating appetite and energy expenditure, and often have coexisting other endocrinopathies. But again, the majority of our patients will have polygenic obesity. And once we've sort of landed on polygenic obesity, and that's where we're aiming for. And really, even if it's not polygenic obesity and you're seeing a patient with monogenic, syndromic, or hypothalamic obesity, I think the 4 M's framework applies. And the 4 M's framework, that's the areas of health that can be impacted by obesity, or can make weight management more difficult. And the 4 M's of pediatric obesity include your metabolic health, your biomechanical health, your mental health, and your social or milieu health. And when I think about metabolic health issues, these health issues tend to run strongly in families. So if you have a young person who does have a family history of type 2 diabetes, for example, or PCOS, they are going to be at higher risk for having some of those metabolic health issues themselves. Metabolic health issues are also silent, so important to screen for them because they're often asymptomatic. and the time in a young person's life where they're more vulnerable to have these metabolic health complications show up is puberty, because puberty is an insulin-resistant time, and most metabolic health issues are driven by a component of insulin resistant. So when we're going through that rapid growth of puberty and we have excess growth hormone around that's driving that height change, we are more likely to have our we may be more likely to have some metabolic decompensation at around that time. So we do recommend screening for metabolic health issues beginning at age 10 or earlier if puberty has started earlier, which is quite common for girls living with obesity. So the first sign of puberty in a girl is breast development, and many of the girls we see will have onset of breast development before age 10. So you want to start screening for those metabolic health complications at around the time of puberty or at age 10 and annually thereafter. And that includes a fasting or random blood sugar, an A1C, an ALT, a urine albumin to creatinine ratio, creatinine, and then do those annually. And your lipid profile, sorry if I didn't mention that. So metabolic health issues are very responsive to lifestyle intervention. You don't need much change in body weight to see nice improvements in metabolic health issues. So they can be quite rewarding to kind of see those changes over time. Biomechanical health issues are more challenging for me as a health care provider, because they can be complications of having a higher body weight, but also can make weight management more difficult. And so those include, and those you're going to kind of pick up on your history in terms of, and your review of systems, asking about symptoms of sleep apnea, musculoskeletal pain, things like stress, incontinence, reflux, and intertrigo. So important as health, I think our patients share that sometimes it's hard for them because when they approach a healthcare provider with concerns for biomechanical health issues, often they're told that they just need to lose weight for those biomechanical health issues to get better. But I think it is critical that we as healthcare providers provide support or help with support in managing those biomechanical health issues in order for our young people to be able to successfully manage their weight. So yeah, I think I'll pass on to Laurie to talk about the mental health and milieu of the 4Ms.
Okay, and I might go a bit backwards here and start with milieu. So if we think about, you know, sometimes we think about our patients or families as the impact on their health can kind of in concentric circles. And so the milieu is sort of the biggest circle of things that might seem like they're far away from health, but they actually have a big impact on day-to-day health and how families can carry out health behaviors. And really simply put, sometimes we think about both the stress load on the patient or the child and the sort of load on the family, and taking those into thinking about those when we're making suggestions in terms of what families can be successful at. So if we're thinking about the sort of load on the family or on parents, it's what types of family stressors might they have going on? What are parents' physical and mental health like? Do they have the capacity to add on extra sort of work in terms of efforts for health behavior change? We need to think about their socioeconomic status, so their income and what they can afford to do in terms of nutrition and activities, and also whether or not they have free time or time that's not spent working or caring for the house or doing those things. And the other piece that sometimes goes along with that is neighborhood safety. So thinking about the neighborhoods our families live in. Are there safe parks kids can go to? Can they go for a walk? Is it safe for kids to be outside on their own at a certain age? Are they living in a food desert, so to speak? All of these things sort of impact, what suggestions we might make in terms of what's feasible for the family. Um, and then the load, sort of stress load on the child, um, can we can look at the school environment and climate in terms of how supportive, what the opportunities for extracurricular activities are within the school, even within classrooms or cohorts of kids. Um, are the kids in a class where everybody sort of rallies around each other and they know, sort of take care of one another, or are they in a more of a cliquey classroom where you're either in or you're out, or there's lots of sort of social aggression and peer relationship issues, because that can have a big impact on sort of day-to-day functioning for a child. I think one of the things that we need to pay a lot of attention to for our patients is bullying, the impact of bullying, particularly weight-based bullying, um, and whether or not it's happening both at school or within the family. And then just being really cognizant of weight bias and stigma that might be happening at school, at home, in other areas of their life. We know that, you know, within the school system, within healthcare, within um, employment, that those who are living in a larger body are often discriminated against. And so kids who are larger are often sort of seen as being less smart, more lazy, less compliant, even when their behaviors aren't different from other children. There's definitely a bias there. So that's sort of our milieu and what we're looking for. Um, and of course, the other big one is sort of medical insurance for other things like medications or physiotherapy, occupational therapy to help with health. And then the fourth M is mental health. So there are a number of mental health conditions that are associated or seem to be more prevalent in our population, or in those living with obesity. Um, and so we see, I think, anxiety and depression, we often think in mental health that they kind of hang together um, in terms of prevalence. And oftentimes what we see is because of this, the weight bias and the focus on weight in our culture, that we do see quite a bit of social anxiety in our population related to weight-based bullying and teasing. And I think this has really increased since the pandemic overall in terms of what we see in children of all shapes and sizes. Social anxiety, I think, has increased since the pandemic began. And so for our kids as well, thinking about if they have anxiety related to being around other kids, fears of bullying or teasing, fears of, how they'll look, or whether they'll be accepted in a new extracurricular activity. You can imagine if we push them to, join a soccer team and they already feel, they've got some anxiety about connecting with other kids, and then they've got some anxiety about whether or not they'll be able to keep up with the other kids, or others will make fun of their weight. It adds a whole level of sort of anxiety on top. With depression, I think this is also, with anxiety and depression, it's a bidirectional relationship with obesity, in that some of the symptoms of depression and anxiety can often lead to weight gain. And then living at a higher weight can lead to some anxiety and depression because of the impact that both difficulties can have on sleep quality, um, the way kids are approaching eating, whether or not there's disordered eating, and then the biological factors that we don't know enough about, neurotransmitter function, neuroendocrine function markers, the gut biome. These are all areas that are being investigated. And there's questions as to whether there's common sort of pathways that would make people at higher risk for both obesity and anxiety and depression. The other one that we need to think about is ADHD in terms of both sort of perhaps leading to weight gain and obesity, but also impacting treatment efforts. We do see higher rates of ADHD in our population. And conversely, if we look at those with ADHD, we do see, I think we used to think about the really thin kids who are on stimulants and worried about getting them to eat enough. I think that's only one part of the population. There's also, we see higher weight in kids with ADHD. And the proposed mechanisms are around executive function, so being able to plan, being able to be organized for extracurriculars, taking a lunch, that sort of thing, but also the impulsivity that comes along with ADHD in terms of impacts on food choices, and sort of how inviting screens are, to put it nicely. And then the third, one of the other pieces that we need to think about too is any learning disorders. Learning disorders can often make school really challenging and make kids want to avoid school. But also some of these learning disabilities also come along with, seem to put kids at higher risk for coordination issues and things like that, which makes physical activity difficult. And of course, sleep disorders, shifted sleep schedules, things like that, can also show up in our population. So maybe, Stasia, I'll get you to go on to the next slide. So two of the areas we spend a lot of time on, and that I think are really important for our population, even more so than the others, is body image. We know it's a strong correlate to disordered eating and to obesity. And we know that it's the most important sort of domain of self-esteem in boys and girls and in men and women. So we used to sort of talk about, you know, kids within the sort of tween teenage group of knowing that body image really had a, you know, took up a big portion of that self-esteem pie, so to speak, in terms of how kids see themselves and how they see value in themselves. But I think we know that across the lifespan, it seems to be an important domain that impacts self-esteem. And so the question sometimes is, how do we assess body image, and how it's, and I think clinicians often have the same sort of anxiety they have about bringing up the question of weight, is I don't want the child to feel like we're saying they should have, be concerned about their weight, or we don't want to say anything negative to cause harm, right? So I always start very broad and sort of work my way into a more targeted question, but I'll often start with, explain this is something I ask everybody your age. Can you tell me how you feel about your health? Do you have any concerns? And so this might come up again. You're sort of starting this assessing body image when you're also assessing whether they have concerns about their weight. How do you feel about your body? Do you feel, and if, it's a little kid and they go, well, what do you mean? And I say, well, do you feel good in your body? Do you feel beautiful or, handsome? Do you feel like confident in your body? Is there anything you would change about your body? And if they say, if we're getting to, well, yeah, I think I need to lose weight, or I don't like my body, sort of things we kind of raise red flags for me is if kids are avoiding, don't want any pictures taken of them, avoiding mirrors, avoiding, they'll often be wearing really, really covering up their body in terms of baggy clothes, not wanting to wear shorts or t-shirts in the warm weather, not wanting to go swimming. And so I think Stash and I will both ask in different ways, but, do you feel like, if they've said their weight is an issue, do you feel like your weight makes anything, you know, more challenging for you or more difficult? And really what we want to know is if it's sort of how they feel their body looks or seems, and whether or not it's getting in the way of them doing things that they want to do or need to do, so that we can help provide the right supports. Maybe I'll have you go on to the next slide, Sasha. Thank you. When we want to ask about disordered eating, so binge eating disorder and binge eating, overeating is not sort of, I think people think it's more prevalent in our population than it is. That being said, it's also, binge eating disorder is probably the most prevalent eating disorder. There's estimates in the pediatric population that it's somewhere between 15 or so percent and maybe up to 20% in adults of the population living with obesity engage in some binge eating. So it's not every child. We don't make assumptions that they are engaging in binge eating, but on the other hand, we want to assess whether or not they are, so that because it really does impact how we go about supporting them. So the three kind of areas or things I think about with disordered eating is whether or not we're engaging in any emotional or disinhibited eating, whether we're engaging in binge eating, and then whether or not atypical anorexia, which I don't personally love the name. I think it's whether we also need to be on the lookout if we do see a growth curve where, they've really lost a significant amount of weight in a short period of time, and it's not well accounted for as to how that happened. We do start to worry about that they have stopped eating, they have anorexia, and we know that the physical complications of that in terms of heart rate, all of that stuff is the same as it would be for a child who's gone from sort of a BMI of 22 to a BMI of 17. The impact is the same on the body. So again, with asking about sort of disordered eating behaviors, we start really broad. Have you ever tried to change the way you eat? Can you tell me about that? And why did you, can you tell me why you decided to try that diet or whatever they say they've done? And again, you'll have a sense of, was it to lose weight? And that opens your door for things. And then we also like to ask, does anyone in your family eat differently from the rest of the family? Or is anybody on a specific diet? It gives you a sense of sort of the food landscape as to, and whether or not there's a lot of diet culture or diet talk in the house, or whether, other parents are eating differently because of a medical condition. All right, Stasia. Thank you. When assessing for binge eating disorder, I'll often ask kind of directly going, the DSM criteria is that people are eating a large amount of food, more than most people would eat in a very sort of distinct period of time in a kind of a 2-hour window. And that they feel a loss of control over their eating during those periods. And they have a lot of distress around the binge eating. And it's happening at least twice a week for 6 months. However, I think we find that the distress, the market distress they talk about, I'm not sure we always see that, or kids are able to, I'm not sure if it's kids can't acknowledge it, or they've blocked those emotions so well that that they will say no, that they're not having any distress around it. But we are sort of looking for not just eating seconds or maybe overeating at Thanksgiving dinner, but more of this, loss of control, disinhibited eating till they're uncomfortably full, eating in private, oftentimes because of embarrassment, and it becomes quite secretive. So though, and it can often happen, kids, if they're able to be open about what's going on, will often say like, yes, I'm going to have a binge now because this is the time when I can have the binge. When everybody's out of the house on during the day, or after school when they start to eat, and they, if they haven't had breakfast and lunch, and it kind of they lose control. So there are often patterns to the binges, and unfortunately for kids, it's often sometimes they will wait until everybody else in the house is asleep at night to sort of be able to access food without others making comments. And then, of course, it's also then interrupting the amount of sleep they're getting. Can go to the next slide, Stasia. Emotional eating, I think, is also really important and much more common in our population. And the first thing I will say is, myself and the dietitian, we always normalize this, that everybody engages in some emotional eating at points because they're bored, or they're upset, or they're stressed. I think everybody probably has done that at some point. The issue is when it's their only coping strategy, or it becomes a regular habit. And so I will often kind of have a chat. Sometimes people's eating changes when they're, more stressed or upset or even bored. Does that ever happen to you? Do you, some people eat more or less if they're upset or scared? And usually they kind of know what I'm getting at and can answer. We often hear about lots of boredom eating. So those kinds of things to look out for. Which also reminds me, there is a little book that we often give to kids, younger kids, about the different types of eating that would be helpful. And the last thing I'll say about assessing the disordered eating behaviors is there's a ton of shame around binge eating, emotional eating, because kids feel like, as adults as well with binge eating, feel like their weight is their fault, and it's incredibly shameful, and they don't want to get in trouble. And so oftentimes it doesn't come out for several months, even if we know that parents have said, large amounts of food are going missing and things. It's really difficult oftentimes for kids to talk about it.
So just going back to the two examples that we had earlier on and applying the EOSS-P. So we first met Jeff and Erin. So you've completed your 4 M's. For Jeff, he has no metabolic health issues. He's doing well biomechanically. He's doing well from a mental health perspective, and he's well supported at home and in his community. So although he has class 2 obesity or severe obesity based on body mass index, he has stage 0 obesity based on the EOSS-P, and that will affect your management or intervention strategies. For Jeff, our role is to continue to be there to support him in all of the wonderful things he's already doing, and support his positive health outcomes throughout the years, and of course reevaluate his metabolic and biomechanical health at regular intervals, and mental health, to make sure that he stays well. Sorry. And then Erin also has severe obesity based on BMI. He has stage 2 complications within metabolic health, in that he has a diagnosis of type 2 diabetes. He has stage 1 mental health with the coexisting diagnoses of ADHD and a nonverbal learning disability. No biomechanical health issues, but where he's really struggling is social health, and really thinking about how can we support that social milieu to help him successfully manage both his type 2 diabetes and his body weight concerns, and also considering treating ADHD to support managing his metabolic health as well. But I wanted to go back to Alex, who we met at our first session together. So we're going back to Alex. He's a almost 13-year-old boy. He has class 2 obesity based on BMI. We know he was born large for gestational age, which can be a risk factor for obesity. He was also a colicky baby with some reflux, and food was soothing for him in his early years. He's always been tall. He's had a normal growth velocity, so no evidence of endocrine issue. He has no neurodevelopmental concerns, and although he has an interest in food, he doesn't have any hyperphagia to suggest any monogenic or syndromic forms of obesity. As I said, he's had a higher weight and been taller than his peers for most of his life, but interestingly, at around the time of his parents' separation, which was a stressful time for him, he gained weight more easily. That was also somewhere at the tail end of the pandemic. After asking permission, Alex shared that his body weight or size, he does feel like it holds him back or slows him down in sport, and in particular running. It impacts his social comfort, confidence, and mood, and has resulted in him kind of withdrawing from physical activity and social activities to some degree. He shared that he has tried to decrease weight through dieting, a ketogenic-like diet, with the support of his dad, who thought that increasing his protein intake might help with having him feel more satiated. But after a few months, Alex became quite tired of the keto-like diet, and they left that behind. And interestingly, parents had different views on whether or not that was the right thing to do for Alex. So Alex does feel that with weight loss, he'd be happier and more confident and be doing more things. He has not experienced any bullying, but fears judgment from peers. When talking to parents alone, they both shared concerns for Alex's low interest in activity. And he's a kid that if he doesn't feel good doing it or successful doing something, he may not persist. He doesn't feel, I think he needs to feel successful in order to continue. And that has led to some withdrawal from some physical and social activities, although he's had different opportunities for those. And the parents report, although he didn't share this with me, parents report that they've noticed that he's wearing larger clothing, multiple layers, even in warm weather, not comfortable, wanting to hide his body. And parents also shared that between them, the separation was a difficult one, and they have some ongoing communication struggles and communicate primarily through email about the children. This is his growth velocity, again, tall, young person, and a bit of a crossing upward of percentiles for BMI. And then when we go through the 4 M's for Alex, biomechanically, he did report some snoring and maybe a little bit of low back pain, not interfering with activity. So it made me think, okay, maybe I should consider a sleep study and just keep an eye on this back pain that he's reporting. From a mental health perspective, I was concerned that he had some mild body image concerns. He has some perfectionism, and he did share some boredom eating was happening for him. So when there's not much going on, he's more likely to think about food or want to snack. Metabolically, his blood work looked perfect. So blood sugars, cholesterol, liver enzymes, kidney function, all normal. But he was born large for gestational age, so he may be at higher risk for metabolic health issues. And then social health, I was concerned that there were some social stressors for him. The recent separation of his parents, some communication difficulties between parents, and the parents had a different approach to feeding. And it was interesting, the food environments are different in the different homes. He goes 1 week to mom, 1 week to dad's. And while dad felt like dad felt that Alex was kind of recognizing fullness more, satiety more easily. When he was at mom's home, mom felt he wasn't. And I wasn't sure if at dad's there's less kind of, there may be less food available or more restrictions. Then when he goes to mom, it may be a time that he may feel that he may be a bit, because he's restricted in one home, he may be a bit more vulnerable to emotional eating in another. So that was just something that came up. So when we complete our assessment, to help frame things, we like to complete our 4Ms table and try within the 4Ms to identify some potential things that might be driving weight gain for the person that we're seeing, and maybe some barriers, things that we might have to kind of work on and address to achieve success in terms of our health outcomes. I was really happy that he was really mostly free of any metabolic or biomechanical health issues. I felt he was vulnerable for potentially some low mood, and some symptoms of social anxiety related to his feelings about his body weight. And I thought we needed to be, mindful of what was happening for parents in terms of their relationship and their communication, and potentially their different approaches to feeding and nutrition. So in terms of drivers for him, I thought polygenic obesity, there was a family history of obesity, the fact that he was born large for gestational age. So those are non-modifiable drivers. He did open up about boredom eating, so that might be something we could explore. And then this dieting history can sometimes lead to more weight gain over time. So really watching that restrained eating in one home might not, might be contributing to increased eating in another home and potentially driving weight gain. And then some barriers for him. I was worried that his feelings about his body weight could potentially be a barrier to him engaging in health behaviors that could help him manage weight, and kind of withdrawing from things that might have a positive impact on both his physical and mental health. His perfectionism and getting him comfortable with not always, that he didn't always have to be successful or do things perfectly. I thought we needed to be mindful of the communication difficulties between parents. Yeah. And then so out of that, sort of picking a few areas to focus on to help support Alex as a start in a collaborative way. The things that kind of came out were body image, some social comfort, confidence, resilience, managing hunger throughout the day, and making sure we're mindful of family needs and family supports. I don't know if Laurie, you want to add more to that that's sort of the way we walk through the assessment and our EOSS-P, and sort of identify some places to start.
Yeah, I don't think I have much more to add, only that if we're looking at even physical activity, or trying to get him to reconnect to his peers and things, we need to have a good understanding of sort of why he's withdrawn and whether or not that's related to body image or not, so that we're not sort of setting up for failure of, you should, go and do all these things when you don't feel comfortable kind of stepping out the door.
Perfect. So I thought that this might be a nice place to kind of open up for questions, to see from all of you whether this kind of approach feels feasible or gives you sort of an organizational structure for your assessments, and also take any questions about how to complete the assessment or the EOSS-P or anything.
Oh, that's opening it up, Stasia. Anything at all. So folks, please use the Q&A on the bottom of your screen, and don't be shy. Pop your questions in there. I'll kick us off just while we're waiting. So you guys know, like, nationally, we have really, really huge variability in terms of team supports and clinical context for doing this work. Could you share some pearls, like if someone maybe doesn't have access to team, perhaps has more constraints, or you're dealing with a family that might really struggle to get in, like ways that you've had success in terms of supporting colleagues in doing this work, which seems very comprehensive but potentially lengthy?
I agree. Yeah, I think I guess the one thing I would say is not feeling like you have to do all of it uh, all at once, for sure. So if you've just gotten to the ask and you want to sort of work on your 4Ms, I don't know if I've been a pediatric endocrinologist my career, so I feel like as I work with you have a more intimate understanding of what it's like to practice, as a family physician in the community. But I think what I would imagine is these conversations can happen. Remember, this is a chronic condition, much like your approach with hopefully your patients living with type 2 diabetes or your patients living with hypertension or any chronic disease. You can really take your time. There's nothing super acute here that we can kind of work on together. So you open the conversation, then maybe when they're ready, they come back for an assessment. And you maybe just focus on 1M at a time, even like, okay, today we're just going to review your metabolic health and what's happening there. In terms of coaching around lifestyle, I think the main areas that we focus on, if I don't have a dietitian, the main things that I'm looking at are you getting enough sleep? What might be interfering with sleep? And then how are you managing your hunger throughout the day? So are you eating regularly throughout the day? Is there a time of day that your body feels most hungry? Any loss of control? And then just working on regular feeding. Nothing about what you're eating. I don't ask any questions about what you're eating. I ask about how you're feeding your body and what might be, whether there's emotional eating or boredom eating. And then at another time, what's going on from a physical activity perspective? What has been your experience of physical activity, positive, negative? But I guess, sorry, I'm not answering your question well, but I think my message is break it down, take your time. If you only have 15 minutes at a time with your patient, I hope that you can feel comfortable that you don't have to complete the EOSS-P in one session. Like you can gather that information over multiple visits if that's feasible for the young person and their family and for you in your practice. And I don't know if any of you have ideas. I don't know if Laurie has more to say about that.
Yeah, I know you only have little short periods of time, but I would agree that it's sort of and some things you may already know about the families you're working with, so you don't have to ask all of these things, but you start, I think, little by little and trying to put the pieces together and starting where either you have the most concern based on whatever data you have, or where the family is most concerned, or I'm worried about their weight, they're getting teased or bullied. Okay, do you have somebody maybe that you can talk to about the bullying? Do you have extended healthcare benefits? Is there someone at school that they could talk to? Have you talked to the school? That kind of thing, to sort of, you don't have to assess all of these things, but if there's things coming up, can you also connect them to others that might already be sort of available to them to help with some of these things.
Mm-hmm. Cool. We have a couple questions. So the first one here is, you gave the example of the two parents that had divergent views, for example, on the keto diet, or perhaps two parents who have divergent views on what's being shared, from the treating professional. How do you manage those dynamics?
It's a good question. Carefully.
I think with this couple, or these parents, sorry, they came in and I just sort of I think just asking questions around why how the decision to bring the keto-like diet into the home came about, and where did that information come from, and what was kind of driving that to the dad. and then allow mom also some space to talk about what her concerns were around what made her feel a little uncomfortable around introducing that, and then just also sharing some information with them. Like, is it okay if I share some information about what we know of what we know of, or what some of the concerns might be around the introduction of a diet like that. Now, for him, it was pretty, like, dad was able to see, like, by that 3-month mark, Alex wasn't interested, like, was struggling with it. And then we sort of brought up the point, well, I wonder why, do you think that maybe what mom is seeing when he goes to mom's house might be related to the fact that there's different food available there? So just in general, I find asking the questions and getting the family to kind of think about some of the things that could result from different approaches to diet, to get them to kind of come to the recognition that maybe the restriction could be causing some challenges for Alex, and have the opposite of the intended effect, or the opposite of the intended outcome, and bring them together that way. Ultimately, both parents want the best for Alex, and as sort of coming to some middle ground together, sort of helping them get to that place. Again, I find in general, just shutting it down that doesn't work particularly well. Like, if I was just to say, well, we don't recommend ketogenic diets in kids, I feel like I would completely lose my therapeutic relationship with the father. And I think I needed to just walk that line a little bit, and just through asking some questions first. Yeah, sorry.
Mm-hmm. No, that's great. The next question from Chelsea was just around, penetrance of the knowledge about these spaces, right? Which we're all working on around how do we build awareness? How do we help people know? How do we help treating professionals know about some of these new resources and things? So Chelsea's questions around how could you suggest parents request pediatricians to use the tool? Or have you got thoughts on that one?
Yeah, I mean, I think we've often had questions around, well, I went to another provider and they've just said, this is my BMI and this is unhealthy and we need to lose weight. And maybe weren't helpful in sort of suggesting what the issues were, or how to manage weight differently. It is tricky. I think I would encourage them to do the same thing we do with them, is to, sort of ask the question, is BMI the only marker of of health that's we should be focused on? I have heard, there's some other ways of looking at health that including this. Is this something that would be applicable to my kid?
Mm-hmm.
I know there was also some press around the clinical practice guidelines that were released in April. So sometimes I might share with parents to say, hey, I had heard this on the radio that these, do you think these apply to my young person? Can we go through them together? I heard this on the radio, or I saw this on CTV that there's these new clinical practice guidelines. Could we walk through them together? Do you think it applies to my son or my daughter?
Mm-hmm. That's a nice way to do it. And I know, I think, hey, Jamie, I saw that you put a question in the other chat, but now I can't find the question. So I feel like we're shortchanging Jamie. Gosh, I don't know, but there is a link to the EOSS-P tool in the other chat, guys, and we'll send this out as well on our Pearls document. So thanks, guys. Just feel like this is run through so quickly. And it's been great. Oh, and you added it to the Q&A. Oh, thanks, Jamie. Okay. Last question. So how do you manage expectations from families that want to take away tips and strategies after the first appointment? I find people want goals or actions to take before the assessment is complete.
Yeah, it's we got to go now. Like we're ready and you want to build on that. I think if I can put you off for a week, I think next week we're going to talk about sort of how to like the last three A's, like agree and advise on what we do with some of the information we have and how we present it to parents and what little like suggestions might be, again, things that families might choose to focus on or you might choose to focus on with families. So yeah, and we have a little discussion in there too, I think, about setting expectations for what change is going to look like and that sort of thing.
Yeah, no, awesome, Jamie. Great question. And I mean, I think too, we can always give people some resources to look at between visits. That's something I think in primary care, it's a fair furball because the visits are short.
Mm-hmm.
I find giving people stuff as handouts is really helpful. But you know, gives people something to kind of look at and stay engaged with between visits, which might be a bit spread out. Yeah.
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 So awesome, guys. Thank you so much. So looking forward to next week. Off to clinic. So thanks again. Thanks everybody for taking time at lunch. So awesome. Really appreciate it.